One of the major mistakes I see physicians, particularly early stage trainee physicians, make in terms of having conversations with patients and their families that are facing end-of-life issues is very simply to not talk about it. They ignore it, they talk about something different, maybe they focus on a problem of the day, maybe, you know, the urine output has decreased a little bit today, so we'll talk about that with the families. And getting sort of hung up on the details as opposed to staying, for the families, staying really broad to begin with, and then getting down to the details if necessary. And 9 times out of 10, you don't need to get into the details of, you know, how the body is shutting down in all these various ways. You don't need to get into those details with everyone. And sometimes it's just very simple to say, you know, today's a bad day and I'm starting to get worried. And so I often see physicians not say that, just say, well, today we're working on X, Y, Z, and being very factual, as opposed to giving your opinion. And sometimes we're trained not to give our opinion, to be scientific and rigorous. And I don't think that, in my experience, I don't think families appreciate that as much as they appreciate hearing what your opinion is and saying, I'm worried that X, Y, Z. And so I use the word I'm worried a lot because it also gives me a little bit of an out, because I don't know that the patient is dying, but I can say, I'm worried that we're approaching an end-of-life situation here, or I'm worried that we're seeing so many abnormalities in the lab tests that we're getting to a point of no return. And so personally, I like that language, and I think it helps me to reach my families. For some families, you do need to get down into the details, I find. So for some families that maybe you start broad and they're just not understanding, or you can tell that there's resistance, that's when I think that sometimes it helps to say, okay, here are all the reasons that I'm having this worry, or I'm talking to you about this today. And it's because I've noticed the kidney numbers are getting worse, and I've noticed that the breathing machine, we're turning up the levels on the breathing machine, and I've noticed that we're turning up the numbers on the blood pressure support medicines. And so I start counting things for families that have a hard time sort of grasping and are looking for the details. I start counting things on my fingers, and I say, you know, that's 6 things today that have me really worried. And yesterday I didn't have 3 of those 6 things as a concern. And so that's why I'm saying what I'm saying today. And then maybe the next day, 3 of those things have gone away and we've turned a different corner. And I can say today we've only got 3 of those things. And so they can see the ebb and flow. And I find that to be a good approach for patients that really need to get down in the details, is using your fingers. One of the problems that I see physicians often encounter is trying to get a code status, trying to find out, okay, what happens if the heart stops? Do I do CPR, yes or no? Do I put a breathing machine in, yes or no? And getting that code status is so important, and I don't mean to diminish it, but it's also not the primary goal of the conversation. It's sort of the outcome of the conversation. And so figuring out what the goals are, and then aligning the treatments that we would or would not perform to match those goals, to me, that is the way these conversations about code status should go. And rather than starting with, do you want us to do CPR and restart your heart if your heart were to stop? That's a little bit of a loaded question, and I think really hard to answer. If you're not sure what CPR is, if you're not sure what the outcomes of CPR are, it's almost impossible to answer. And being that we're not great at prognosticating as clinicians, I think it's hard to explain to families in the context of CPR, yes or no. And so I personally advocate to avoid trying to get that checklist of we would do this and we would do this and we wouldn't do this and there's a feeding tube and there's not a feeding tube. All of that is sort of less important than the goal of what is it that we're trying to achieve. And then once we know what we're trying to achieve, then we can kind of go in and say, okay, now here's something we could do. should we do this? Will this achieve our goal? And framing it in that context. So I think that's an important approach to having these conversations.